Welcome to the NMSK podcast from the American Osteopathic College of Physical Medicine and Rehabilitation, the AOCPMR, the home of osteopathic physiatry since 1954.
Welcome to Grand Rounds Reimagined. We explore physical medicine and rehabilitation through an osteopathic lens, one conversation at a time. I'm your host, Dr. Haroon Andar. So grab a cup of coffee and let's get into it. Welcome to the episode of the Neuromusculoskeletal Grand Rounds podcast. I'm here joined with a prominent physician that I've been very excited to interview actually this week, Dr. Yasha from New York City. Dr. Yasha, you completed your PM&R training over in Nassau
University Medical Center.
Great. And you then completed a subsequent sports and spine fellowship?
At Performance Spine, a private practice group in Pennsylvania.
Great. So, I understand you have now created and built a practice over in Manhattan, New York. You call it Network Spine, from what I understand. And you deal with a lot of regenerative medicine, a lot of musculoskeletal, sports and spine. Please tell us a little bit about that, if you don't mind me asking.
Well, it's kind of a natural extension of PM&R training because PM&R is really a lot of overlap with sports medicine. And my practice developed initially as a pain practice, but I was getting so many athletes coming to see me, a lot of jiu-jitsu and MMA guys. You get a lot of sports medicine, and that's kind of really becoming a bread and butter thing for the practice.
Great. All right. And you do, I understand we were just talking about this a little bit earlier. You do a lot of PRP. Do you do a lot of leukocyte rich, leukocyte poor? Can you please tell us a little bit about the differences and what you have seen in your practice?
So in my office, I use leukocyte rich PRP. Okay. And part of that is because that's the kit and device I have. In my surgical centers, I'll flip back and forth between leukocyte poor and leukocyte rich. I favor leukocyte rich for the intradiscal procedures because the literature supports it and there's a lower infection rate.
Right.
Outside of that, there is conflicting data on what's better. Leukocyte poor doesn't seem to be as irritating.
Right.
So if I have someone who's a little more pain sensitive, I'll favor that. I bias a bit towards leukocyte rich just because of the lower risk of infection.
Great. And I believe I did read a study once. I tend to use a lot of leukocyte poor in my practice. With regards to leukocyte rich, I do remember actually from New York, Dr. Gregory Lutz, who's kind of the godfather of intradiscal injections with PRP. He wrote a lot of literature and research back in the day, who passed away, God rest his soul. But he said at that time, using leukocyte rich for intradiscal, he noticed better outcomes for the patients. They did much better treatment-wise. And I think one of the theories that he postulated was that the leukocyte rich was able to have those neutrophils necessary to fight against. It was a bacteria, I believe he had said, that was causing degeneration of the disc, actually.
Yeah, there's a theory behind that where there's some type of subclinical infection that's causing pain. And when you're putting something like leukocyte poor or BMAC into the disc, that could be this very rich growth matrix. Right. And when looking at the data, there's much lower infection rates. And when it comes to discitis, it's such a big deal. It's not something you want to mess with. So I favor leukocyte rich for that until there's better data saying otherwise. That's what I'm favoring.
Nice. Yeah. And when you do this, you also do the standard 1 gram of ANSEF.
So sometimes I'll combine it with a discogram.
Okay.
And just to see what it looks like. And with that, I'll mix in a little bit of ANSEF.
Great. Do you do any stem cells, any BMAC, anything like that?
I do BMAC. I've had some really amazing results with BMAC. A lot of it's in the office. I use heavy local sedation,
Gotcha.
Maybe 10 to 20 mLs of 1% lidocaine over the PSIS, flood the area, wait about 5-10 minutes, and then I'll go in. I can also do it at the surgical center. Usually the cost sometimes is a factor, so we do it with local, and the patients do great. They really do.
So I want to take a second because I know you and I both see this. I see this a lot. you'll look at your schedule, you'll have a 35-year-old weekend warrior or a 40-year-old weekend warrior who went to the gym. He suffered a recent injury. He tried his therapy. He didn't get any relief. He got a consultation with a surgeon who recommended surgery, and he's kind of looking for a non-surgical option at this point. He's coming to see you. How do you have that conversation about his options and presenting regenerative medicine as an alternative to try first before surgery?
So I almost always offer that as an option to all the patients just so they're aware.
Gotcha.
But what I will do is I will give caveats and say, look, this is what it looks like. This is pretty bad tendinosis. There's a partial tear. I think you're a very good candidate for PRP or BMAC to treat this. Or if I'll see, look, there's not that much left to graft onto. And I'll say, look, we could try it, but this really may not work. You may be better off just going to a surgeon. So it really depends on the tear pattern, how bad the damage is. But if I think they have a chance, I'll let them know.
Right.
If there's a complete rupture, like in a totally avulsed tendon, there's, I don't want to, this is something that a lot of people are paying a lot of money out of pocket. So you really need to provide good outcomes. Because if you don't, you're going to have a lot of very upset patients. So you want to create everything in your favor.
Absolutely.
When you have, and the nice thing is to make you look better is there are some overzealous surgeons.
Right.
And so you can say, like, look, this is really what I feel like you should do.
Right.
But there's a lot to it. The patient selection is really a big deal, and making sure they have the right findings that support a good outcome. And then if they don't, just make sure they're aware that it might not work that well.
Right. No, and I firmly agree. We've all had that. I had a patient actually last year in a similar situation, and I think the MRI said it was a high-grade tear. When I reviewed the MRI, I said, look, I would absolutely love to offer you PRP. Do I feel with the degree of the tear it will be beneficial? I don't have that kind of a confidence with this unique one. So ultimately, we can definitely try it if you would wish, but I want you to be very realistic about your outcome. And if this does not offer you the solution that you need, then at some point you will likely need to see that surgeon and have that surgery. I often think it's typically a discussion with the patient and being very straightforward with them.
Did you end up doing that, Regen?
I actually, no. He ended up, after a discussion, he chose not to. He said he just wanted to just see the surgeon. Then instead, he didn't want to cough up the money for that at that point, because costs can be quite prohibitive for some of these patients. And that's kind of the issue that is a rate limiting step almost at times.
It's interesting, but if it wasn't a cost issue, it would be much more popular and many more people would try it. And interestingly enough, I've had usually with a high grade full thickness tear, I steer towards BMAC. Mm-hmm. However, if they're not sure or there's a cost issue, I will try PRP. And it surprised me quite a few times where I think one time I had a Jiu-Jitsu athlete with an ATFL tear and positive anterior drawer for the ankle, really lax ligament. And I was thinking, this is probably BMAC, but we could try the PRP first. And 2 weeks later, he tightened up. And that really shouldn't have happened that fast. It really should have been more of a 6-week response. But 2 weeks later, he's jumping around on the ankle.
Great.
So, every once in a while, some people are better responders. He was young. He was healthy. These are all factors in his favor. He ate well, good nutrition.
Great. Do you do any epidurals by any chance?
I do.
And if you don't mind me asking, because this is a topic I see a lot. I utilize in my practice leukocyte pore PRP. I know there are some, especially with Regenix, they will use lysate. Yeah. Do you use lysate, leukocyte?
I don't do epidural PRP. I've considered using lysate, but every time it becomes a cost discussion when we know insurance will pay for the steroid injection.
Right.
The patients have a tendency to bias towards what's already covered.
Right.
And they do well with it. I mean, epidurals, if you have the right patient, they can do really great with it.
Great.
So I've just never gotten around to doing epidural PRP. I've done facet, SI, ligamentum flavum, every other spinal region,
functional
disc.
spinal unit, yeah.
But I haven't done epidural PRP.
Yeah, I remember I was very hesitant to try it at first, and then I started doing the research and the data and the literature, and I saw there was many studies showing that it worked as good, if not better, than cortisone-based epidural injections. Now, again, all research can have its caveats, but I said, given that due diligence, I can present it as an option. And I will tell you what, in the last year since I've been doing it, the patients are getting great results. I'm seeing upwards of 80% of patients doing very well. In terms of, is it less or more than cortisone-based injections with PRP, I tend to see the same outcome or longer, actually. 20% of the time or 10% of the time, it does not work. So again, it's all about, taking into consideration the patient, their pathology. If they have multi-level spondylosis with facet hypertrophy, desiccation of the disc, decreased disc height, almost degenerated completely. Am I as going to be as successful as I am versus a 35-year-old with an annular disc tear, having back pain? Probably not as much, but that's why I take into consideration their age and everything else what pathology is. So,
yeah, I think my reluctance to do epidurals with PRP. Well, it's interesting because I remember Jerry Malenga. He passed away also,
right,
and his recommendation was just do the PRP for the epidural.
right,
Patients will do well, and even if you're using leukocyte rich, it'll be more irritating, but in the long run, they will do better. My concern is when you're putting concentrated platelets into the spine.
right.
And there's an issue where maybe you don't pick up a vessel.
That is true.
That's I think why you would want or favor the platelet lysate.
Yeah.
But even though Jerry Malenga, who I have a tremendous amount of respect for and was a very knowledgeable thought leader, he recommended doing PRP. And then my concern was, well, what about the platelets?
Absolutely. No, and that's always something to take into consideration. And that even goes with people using Depomedrol.
Yeah, particulate steroid
particulate
transfer. I see that, and I just don't know why these days. It just we did a non-inferiority study when I was a fellow, comparing dexamethasone to Kenalog. Results were still better with Kenalog.
Right.
And when I graduated fellowship, Kenalog put on the bottle, not for epidural use.
Right.
And I just felt like, even if you felt like you were getting better results, just the amount of liability when the bottle itself says not for epidural use,
right,
it didn't make sense to use.
No, I firmly agree. I always tell everyone, every fellow, every resident, I'm like, always use non-particulate dex for an epidural, always. And even for anything you're doing, cervical, lumbar, definitely. If you're doing interlaminar, absolutely. You can use a particulate-based steroid. That's different. But if you're doing anything transforaminal, non-particulate is always the best approach.
Yeah. So, and when you're doing your PRP transforaminal, it is transforaminal, correct?
Just a lumbar. If I do it. If I do anything in the cervical, I don't do it as much. I've maybe only done one or two as a patient that did not respond anymore to steroids, and they were a candidate for surgery. Same thing, they wanted to avoid it. I had a frank discussion. We ended up doing it through the interlaminar method, going much lower volume, and they have gotten relief. But again, this stuff is experimental. I have we're learning more and more about it with the literature as time goes on. But you have to approach everything with caution, make sure it makes sense for the patient. Yeah. Absolutely. So to kind of change the topic a little bit, you mentioned a jiu-jitsu athlete. You have a background in jiu-jitsu, is that correct?
Yes. Yeah. So when I was a pre-med, I was very fortunate in that we had a jiu-jitsu club, and a very famous, very talented jiu-jitsu instructor was teaching there, Matt Serra, a former UFC champion, and he was my trainer throughout my experience of jiu-jitsu. And I was just so lucky. Great guy, great teacher. I started with him. Then I went through the Renzo Gracie Academy. And when I did my residency, he had a school across the street from the hospital.
Right.
So I was just very fortunate to have that exposure. And also the hands-on sports medicine exposure you get from like just a regular jiu-jitsu class is just unbelievable.
Absolutely. I was just telling Amir, even as a physician, the more you're you're active, you're in jiu-jitsu, you go to the gym, you work out, you have a greater appreciation and understanding of musculoskeletal medicine.
Yeah.
Yeah.
And you know your patients. Like it's for someone to come in and for me to say you have to stop, they have to be really bad. Because first one, they're not going to listen. Two, you have to be realistic. You have to say, look, this is what you need to avoid. This is what you need to watch out for. But if you say you got to stop, that's just not going to happen on most athletes. So you have to be realistic. And, that's part of the game. You get hurt. It's part of life. Everyone gets hurt. You just deal with it and you address those injuries, hopefully in a timely manner.
How long ago did you open up your practice?
Just over 10 years ago.
Oh, wow.
Yeah,
okay.
Just over 10 years ago. Yeah. It was kind of one of the best moves I've made. I kind of really just rushed into it. Didn't plan it out at all. It just happened, and I was just very fortunate, very lucky. It worked out very well for me.
Yeah. Do you have any advice for any resident finishing up, a fellow finishing up, or someone who's an early career attending, maybe work for a hospital system, is interested in now developing their own private practice? Do you have any word of advice from your experience in the last 10 years that you would offer them as a word of precaution before they go in, something they should have checked?
All right. So going into business is not the same just as whatever you think it is if you have no experience. Being great as a doctor doesn't mean you'll be great as a business person. The amount of effort you put into being a doctor, you should put a certain amount of effort in becoming good at business. So for every continuing education credit you do to be a better doctor, if you're going to open your own practice, you need to know how to balance your books. You need to know how to negotiate a lease. You need to understand how to manage people. You need to understand how billing works. And these things you are not taught in med school. You're not taught in residency. If anything, the level of ignorance. I'll give one advice. Don't listen to business advice from doctors.
I've heard that a lot. I've heard that so frequently.
It's not even like they're subpar. It's abysmal, the kind of things that I see, and they get away with it, and they've gotten away with it for so long because of wide margins. Those margins are now changing,
Right.
and they won't. And you'll see doctors going out of business, and many of the older doctors are quitting because they're burnt out. They don't want to deal with administrative burden, insurance, the headaches, liability. But in general, I'll say your foundation for business is math. You have to be profitable. You have to keep your doors open. People don't realize how much overhead costs. And but it's also incredibly satisfying. You get to call the shots. It's your show. You get to decide if I want to do regen or not. There are places that they're not allowed to do certain procedures, or there are turf battles in the hospital where the neurosurgeons or orthospine says, no, you guys can't do that discectomy. That's our territory.
That's something I saw myself when I was working for a hospital my first 2 years. And we often forget that. Now, I do know in the private practice realm, you can do everything, but sometimes some physicians still feel like they have to hold back because they don't want to do a certain thing that a neurosurgeon's doing, but that neurosurgeon is sending them a lot of referrals. So you're kind of, do you ever feel like that happens?
You don't care. Like there's certain politics you have to be aware of in private practice. So if someone's sending you business, let's say it's a chiro, maybe you think chiropractic is just nonsense. You can't say that and burn your referral source. Now, if there's an issue where the chiropractor is hurting that patient, what you should do is don't tell the patient directly, have a conversation with your referral source and say, hey, you can really hurt this person and you got to either modify or stop treating them. And that's the right way to handle it. But if they're not comfortable with you saying that, well, then don't get patients from them. If a neurosurgeon doesn't want you to do discectomies, well, go find another pain doctor, go find another sports doctor. You don't want to encourage that unhealthy relationship. You want someone who's going to help support you.
Absolutely. Is there any advice that you would give to any outside of the business perspective, to any resident, fellow medical student that is interested in regenerative medicine and wants to learn further? Because there is no residency for regen right now. There's no specific fellowship for it for the entire year that I know of. Is there any advice you would give how they can learn further in regenerative medicine, what training they can get, where they can go?
Regenerative medicine is really applied physiology, applied ultrasound. So you need that knowledge and the skill. So ultrasound is really a fundamental for regen. Fluoro is also extremely important if you want to do spine and some peripheral joints, but ultrasound is really a key player. So the better you know your diagnosis, the better you can identify the problem, the pathology, the better you can target your treatment. If you're just going blind to a knee or a shoulder, it might work. And it has worked for some people. But if you want to get good outcomes, you really need to target the lesion.
Gotcha. Absolutely. I know I went to Toby conference. I thought that was pretty helpful. I know there's the IOF now, the Orthobiologic Foundation. They have some courses as well. They also have an ultrasound course, I believe, too. So those were pretty helpful. You just honestly, because it's such a wild west frontier of medicine, it's something if you're really interested in it, you have to really put in that effort to learn it. There's no formal didactic training. So you have to find those courses. You have to attend it, which is kind of what I did.
I think the IOF has an excellent program, Toby as well. And there's a million others. It's just constant exposure. You have to get your reps in. You have to just go in there, start scanning and injecting.
Yes. Last question. Well, jiu-jitsu, doctor, having your own practice in New York. What do you want your legacy to be when you hang it up? Yeah.
That's a big topic. I'd like to contribute back to the field. I have some techniques that I developed that have been very helpful, especially over the pandemic when we didn't have access to the surgical centers. So I'd like to start developing that and pass that along.
I think that's beautiful. So that's pretty much wraps up this interview with Dr. Yasha. And be sure to subscribe to the podcast, take a listen. If you have any questions about anything or you have any questions for Dr. Yasha, you can go ahead and send an email to the AOCPMR, and hopefully we're more than happy to kind of get back to you on that. Perfect.
The views, opinions, and factual statements presented in this video are those of the presenter alone and do not reflect the views, beliefs, and/or policy statements of the American Osteopathic College of Physical Medicine and Rehabilitation, its affiliate organizations, members, or governing council. Medical statements made in this or other AOCPMR video should not be treated as individual medical advice. Consult your physician and/or other medical care providers before undertaking or discontinuing any course of medical treatment. You may review the American Osteopathic College of Physical Medicine and Rehabilitation's full medical disclaimer on AOCPMR.org.